Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. Well, you know that I'm excited because we're finally in football season. It's September 10th. We are past our first week. If you are hearing this, you probably know before I do, because I recorded before September 10th, if the Steelers won their first game in Atlanta. And so I'll be either in a really good mood next week or I'll be in a really bad mood. But I have low expectations for the season. I've got 3 fantasy teams going on. So let's hope that it's a good season and I can stay positive throughout my little hobby here. Also, don't forget to check out the Steel City Underground podcast. I do a weekly WTF What the Football for happenings around the league that I just find kind of funny, interesting, and newsworthy or worthy to talk about in a podcast. So check it out. Anyway, this week I'm going to talk about ICD-10 codes. And I'm going to talk about it in a way that I haven't done in a while, but I'm noticing through some of the audits I've been doing lately that there is a problem with some denials that have to do with code claim position. And that on the ICD-10. And what I mean by that is when you submit a claim, where does your code have to be on that claim? What position? And 1 through now, what do we have? 17 or 16 areas versus the 1 through 4 we always had. And I remember back in the day when I had paper claims, yes, I've been doing this a long time, everyone would always put 1 through 4 for everything. Well, that doesn't work anymore. It hasn't worked for 15, 20 years because you have to link, or what they call point, to the line item that goes with a specific code for medical necessity. And it's really important when you are looking at triggering benefits for patients, let's say screenings, for example. If you put a code that is ICD-10 code, is diagnosis, that leads to a specific complaint or definitive diagnosis, and you're trying to say that the patient came in or was scheduled for a screening procedure, whether it be a colonoscopy or a mammography or whatever it is, you're going to get a denial, and the patient isn't going to get their screening benefit, I'm air quoting, which could be no out of pocket for them. So I really want to talk about this claim positioning on ICD-10 codes because it's important to make sure that you're giving the right information, but that you're also, when you're giving this information that and sending this information, that you understand how electronic billing works, where sometimes it just picks up the very first line item sometimes, and that can be an issue when you send, 3, 4, 5 or more diagnoses. And I know some hospitals are putting pressure on physicians to code every possible diagnosis in the universe when they see a patient inpatient, but that's not what we do in the office setting or in the outpatient setting necessarily, especially, and again, I mentioned screenings or if we're doing preventative, whatever, because we have to be clear which line item goes with which diagnosis code. And there is, an area on the claim form that we can point to that when we're adding our CPT codes. And so it's just so important to have this claim position for reimbursement purposes and also for accurate coding. Otherwise, you could have such a problem when it comes to getting your claims paid, trying to figure out, well, where's my denial? Because that actually is, you might get a denial for the wrong code. You go to look at your claim and it's like, wait, I have the right CPT, I have the right ICD-10, but not realizing it was listed in the wrong spot. I see that a lot of times with modifiers too. One of my specialties, most of you know, is cardiology, and I'll see people coding something first, let's say a ventricular assist device with a heart cath, and which the VAD basically keeps the patient alive, and it's the higher valued procedure, and they try to list it first with a 59. Can't do that. You have to list your first procedure without a modifier, which that would be the first one, and then you modify as you have multiple line items. And so there's a similar, I don't want to say contrast, but concept when it comes to ICD-10 codes and linking and making sure you're doing it correctly. Otherwise, you're going to have some claim denials that you just don't know what to do with. The CodeCast podcast is also brought to you today by Decision Health. Advance your coding career this November at the 2024 Advanced Specialty Coding Virtual Summit. Join top experts for cutting-edge insights into orthopedic, pain management, or anesthesia coding. Save $50 with code ASC2024 when you register now at codingbooks.com/events. Okay, so let's take a look at one thing that actually just came out, and I really was happy to see this just in time for my webinar. As you know, we have fiscal years for ICD-10 codes. So when is it, when it's not like January, it's not calendar year like CPT, January to December. The ICD-10 codes, not just the codes, but also the general guidelines, they become effective October 1st through September 30th of the next year. But they call it their, fiscal year 2025. And those just got posted. So we want to make sure we understand how some of that works. I'm looking at page 13, and this hasn't changed, but I know sometimes, or I should say number 13 in the general guidelines. And this is important because it talks about code first, using additional codes, and diseases where there's certain classifications. So there could be what they call, certain conditions have an underlying etiology and multiple body system manifestations due to the underlying etiology. So what your diagnosis also can now manifest or create another diagnosis. And so, for example, somebody with uncontrolled hypertension can then also end up with some renal issues or kidney problems. One of the biggest ones is, or I shouldn't say biggest, but one of the ones that I see often is a manifestation is dementia with Parkinson's disease. So in the alphabetical index, you would codes from the category G20, that would be listed first, and then followed by a code from the F codes, so FO 2.80 or FO 2.81, and they'll show it to you in brackets because the code from category G20, and you're going to need an extra digit, that represents the underlying etiology, Parkinson's disease, and that is sequenced first. And then the codes in the F sequence that I mentioned, that's the manifestation of the dementia that came from the Parkinson's in diseases classified elsewhere or in diseases without what they call behavioral disturbance. So you'll see also code first and use additional code in a lot of the notes, which are also sequencing rules and used in classifications, even codes that are not part of what we call an etiology manifestation combination. But always make sure you look for that. Was it coded, or does it say code first, or use an additional code when you list certain services? You also are looking for C also for another instruction, let's say following a main term. You also might see code also, which instructs that 2 codes may be required to fully describe a condition. But sometimes it doesn't provide sequencing direction, and because that depends on the circumstances of the encounter. That's why it's so important to really read the full note and not make assumptions within the note. Otherwise, it can be a problem when you're locating codes and trying to give the correct level of detail. Now, we know that our I-10 codes can go all the way up to 7 characters. Sometimes we also have placeholder codes with a lot of services. And I think that's important because when you're looking at codes with 3, 4, 5, 6, or even 7 characters, you'll see that in headers sometimes of categories, and then they could be further subdivided with the use of those extra digits in 4th, 5th, or 6th characters, and that just gives you more detail of those codes. So always also look underneath those codes for that greater detail. Also, sign or symptoms, okay, as opposed to diagnoses. So these are patient complaints, and this is an important distinction that I want to make. It is perfectly fine to report sign or symptoms as opposed to diagnoses when a related definitive diagnosis has not been established or confirmed by the provider. That's what that means. And that's in Chapter 8 of ICD-10, Signs, Symptoms, and Abnormal Clinical or Lab Findings, and that's in the R00.0 to R99. And they contain probably, I would say 90% of symptoms, but not all. Some codes for symptoms are in a different section. But remember, once that symptom has been now included in the definitive diagnosis or confirmed by the provider, whether it be through a lab finding, an exam, an x-ray, a treatment, whatever, then you don't need that sign or symptom anymore. So if the patient, let's say, had chest pain and shortness of breath, and the doctor determined that they had atherosclerosis of the heart or they had coronary artery disease, then you wouldn't also code the chest pain anymore, because that doesn't make sense. You have a definitive diagnosis. So it's important to know, where these codes not only sequence on your claim form, but why you can then combine them as well. And, sign or symptoms that are additional that may not be associated routinely with the disease process, they should be coded when present. So let's say that you've got a patient who's got, let me think of something, sciatica, but they also seem to have some numbness in their wrist. That's not related. You don't know it is. It's not routinely related or associated, your wrist versus your, right hip area. And so that is something, if the patient has that complaint, that could be identified separately, as long as, it's not part of that definitive diagnosis of sciatica. So that's where it's just so important not only to read the diagnosis codes and the notes and parenthetical direction around them, but also read your guidelines. The guidelines, or the general guidelines, really just, it's almost like a roadmap to how to use the codes before you actually use them. And I know a lot of people don't like to use directions. They just want to jump right in, but it's important to use those directions. Now, when I mentioned the sequence, and, I want to go back to something on screening. This is something that comes up a lot for you GI coders out there. Hopefully you'll appreciate this. So let's say a patient is coming in, or you're seeing them for screening colorectal cancer, okay? And so they are going to be scheduled for a screening colonoscopy. Well, we have some reimbursement guidelines with Medicare and different payers that talk about related diagnoses and, how you can actually how the patient can have coverage for this. And it's been expanded over the last couple of years. So when you're dealing with colon and rectal cancers, unfortunately, they're the leading cause of death in the United States, even higher new cases and death rates for ethnic Americans, so Black Americans, American Indians, and Alaska Natives. So now Medicare reduced the minimum age for colorectal cancer screening from 50 to 45 years. And it was also in alignment with the recently revised policy recommendations for the U.S. Preventative Service Task Force. So you wonder, why does Medicare care if they're only seeing patients over 65? Well, there's still some disability patients who are covered by Medicare when they expanded it. And then also Medicare, CMS, and covering over to HHS makes up some rules as well, in addition with the Preventative Task Force on what patients should have out of pocket to help prevent some of these diseases if they can, because a lot of patients, they won't get things done if they think that they have to pay out of pocket. Now, in saying that, here's something that talks about the actual listing of the diagnosis codes. So a high-risk person, for example, this is how Medicare will pay for colorectal screenings. Check with commercial plans because they're a little different, but it talks about, over 45 for fecal occult blood and flex sigs, colonoscopies for high-risk individuals. Barium enemas are still age 50, but a high-risk person is one that, because of family history, prior experience of cancer, or precursor neoplastic polyps, or any kind of gene marker, right, for colorectal cancer or other predisposition factors, that's going to be why you screen and what's on the coverage. So you've got, for example, Z85.038 for personal history of colon cancer, colon polyps, Z85.048 for family history. You've got a Z83.71 for surveillance, which also Medicare has said that is considered screening. And then you have the special screening for malignant neoplasms, and that's a patient who has one of these issues, and that's Z12.11. Now, let's say that you wanted to put family history of malignant neoplasm of digestive organs, which is a Z80.0. Well, that's not a coverage for screening. That doesn't trigger benefits because it's not of the colon, it's of the generic digestive organs. And I see that denial a lot. And I know my Coding Corner clients are like, how can you help with this? And as soon as I see that, I said, okay, here's the problem. But the other thing is I also see sometimes where you've got a Medicare payer that doesn't always trigger benefits with the family history or the personal history of colonic polyps. They want the Z12.11, and that has to be on the top line item. And then you point it to, or it has to be on the number one spot, I should say, for the ICD-10 code, and then you point it or link it to the first line item. Now, if the patient ends up, or the physician ends up going in and taking out a polyp, you still keep that on there to trigger benefits. That means the patient won't have a deductible or copay if this is all you're doing that day. For the physician side and for the anesthesia, they'll still have it for pathology and for the facility, but they won't have it for physician or anesthesia. And then if you end up pulling out a polyp, then you would put down the D12, whatever the neoplasm, or if it ends up being cancer, that specified site, cancer diagnosis, but you still link the screening, or you still list the screening as the first diagnosis, because that's why they came in, and that again is what triggers benefits. So when we're talking about the list, or the sequence of diagnosis codes, it's not just the general guidelines, it's not just the ICD-10 book, but you also want to look at the other bodies that are involved in making these rules. And one is the AHA, that is the American Hospital Association Coding Clinic, AHIMA, so the American Health Information Association, and just also, what their guidance is. And I know that they talk about, the Z12.11 is to be used as a principal diagnosis for screening. And then if there's a personal history, then you would go to the Z86.010. Now, I have seen some commercial plans that if there's a personal history, that's what they want you to use, and it does trigger benefits. That's different. I'm just talking about Medicare when it comes to this particular situation. But the thing that you also want to keep in mind too, when we're looking at sequencing for ICD-10 codes and understanding how to code for them, and combination coding, acute and chronic conditions, there are rules that it's just so important. If you don't read anything else in the ICD-10 official guidelines for coding and reporting, try to get through the first 25 pages, okay? And you can Google it, just say ICD-10 official guidelines for coding and reporting, and actually don't forget your CM. And read the first 25 pages, because you'll see where I'm pulling a lot of this from. Just something interesting is under one of the sections it talks about, and I think this is page 14, acute and chronic conditions. If the same condition is described as both acute, subacute, and chronic, and separate subentries exist in the alphabetical index at the same indentation level, then code both and sequence the acute first, because acute, of course, is something that you have to deal with now, and chronic is something that the assumption is made that you may be managing now, but you're also trying to manage in the future. And so they want that acute first, because that seems to be the most urgent, and then the chronic after the fact. So they give us a lot of really good direction on this. I think my favorite thing is that was changed a few years ago is on page 15, number 13, on laterality. So one thing drives me crazy, especially when I do orthopedic coding, is that the patient's got something bilateral, or they have something specific to the right and or left side of the patient's body as far as a diagnosis, and the physician or provider, if it's a mid-level, doesn't identify in the medical record the specific side. Well, two things there. If you care about your patient, identify the side. That's ridiculous. But the other thing is that when the patient has conditions either on both sides, or if it's somewhere in the note, and if it's not documented by the patient's provider specifically, but it is in the medical record from other clinicians, then you may be able to capture that. That is one thing that actually changed. If there's a conflict, though, in the medical record documentation regarding the affected side, then you have to query your provider. But if the doctor just has unspecified, but you find another clinician has said that is the left side, let's say, then you're actually able to pull that out for code assignments. That's an exception. But let's face it, to be legally accountable for establishing the patient's diagnosis, I would really hate to encourage physicians and say, oh, don't worry about it. Your staff can pull it out because you can count on somebody else to say that. You don't want to do that. So it's just really important to be very clear. I know I have a lot of providers, a lot of physicians, a lot of mid-levels that listen to this CodeCast, along with our coders, billers, administrators, and compliance folks, that they kind of say, how can I get around that? And when I see that, I'm like, you're talking to the wrong person. I'm going to try to tell you how to do it correctly so that now this is going to help you get your reimbursement you're entitled to and stop the queries for providers, or at least lessen them, because you have to have clarification in the record. And, when documentation is not clear, especially if there's complications of care, we have to query the provider for clarification when that documentation isn't clear, to get that relationship between the condition, the care, or the procedure for medical necessity. One thing I'm coming across quite a bit, especially in an audit I'm doing right now, is a doctor will say borderline. I'm like, well, you can say that at the time of discharge, okay, because that actually says at the time of discharge or the diagnosis is confirmed, unless the classification provides a specific entry. So there is something called borderline or prediabetes. But if the borderline condition, again, inpatient time of discharge, has a specific index entry, then they're telling us to code it as such, but not in the outpatient. So uncertain diagnosis, not in the outpatient. So whenever there's unclear regarding a borderline condition, it says coders are encouraged to query for the clarification. And so we don't want to be guessing. Guessing not only hurts the patient, but can hurt their future care. It can also hurt the provider if they're ever dealing with an audit, especially a TPE audit. That would be scary. And also if the patient ends up getting maybe the wrong medical advice because of something that was given to them, or they can't get health insurance or life insurance because of a diagnosis that was, I don't want to say assumed, but just basically said, well, it was kind of a pre-diagnosis, or it was borderline. Yeah, we really have to be careful not to do that. I think that entry was added in there because on discharge, it's hard to, who's the liable person if you really don't have a definitive situation there. Okay, so that was my ICD-10 spiel for today. Hopefully you learned some information there. You kind of picked up some things there, and that can be helpful for you in the future, especially because within the next 3 weeks, and remember October 1st, that's when the new ICD-10-CM codes are effective, and when the new general guidelines are now going to be effective for 2025. So they're just around the corner. And we always want to make sure that we are as up to date as possible. I think I kind of listed my personal tidbit for the week at the beginning on football. So hopefully that's good. Hopefully we're getting some cooler weather. I know over Labor Day weekend I made some chili that lasted forever, and we just had a great time with that. And so hopefully I just found a recipe for a really good minestrone soup, and I just can't wait to start making soups and have those for lunches. So hopefully those of you out there are looking forward to that as well. So everyone, make it a great week, a great rest of your day, and thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.